to keep the Medicaid expansion more stable, if that makes sense.
Like,
because that's the deal that they're offering, basically, right? Like,
yeah.
if you want this, it has to come with this.
Yeah, that is a hard question to answer. I don't know that we as an organization have an answer to that, to be fair. I don't think that we have a response to that. I think that's a tough one.
Yeah. A devil's bargain or whatever.
Yeah, I mean, the reason I say it that way is because I know for me personally, the work requirements is definitely, it's a poison pill. We would need to seriously change and have a lot more specifically concrete implementation policy written into how these were going to be rolled out. And they're just, it's such a hard sell because really the impact of work requirements is to reduce roles. It's kind of like cutting the program without passing the cut. So,
right.
So for me, it's like, I would have to say no, but it's really a question for like the board and the executive director at that point, you know?
Right. Given that it's being rolled out sort of in chunks, and that also that like a lot of people are still sort of like unaware of it, do you guys expect the problems that have cropped up to get worse and compound?
Well, yeah, basically. I mean, I don't think that it'll get worse in the sense, like, I don't think the numbers are going to increase every month. Like, it's not going to be 5,000 it kicked off this month, 6,000, 7,000. It's not going to keep increasing in that way.
Yeah.
But the overall number of people who are off the program certainly will.
Yeah.
You know, because it's an additive process. It's
Yeah.
a simple thing. And also, like, going back to the provider concern, I think that the uncompensated care costs, it's the way that those, like, trickle down through the provider community or whatever, I think that is going to be a thing that will get worse and worse over time. Mm-hmm. Kind of like, I mean, the same process that has led to a bunch of like rural hospitals shutting down in other states, mm-hmm. where Arkansas hasn't really had any rural hospitals shut down because we have Medicaid expansion, which has like reduced their uncompensated care costs tremendously. It's going to be like, I mean, it's going to be walking that back. It's going to be moving us closer towards, away from Medicaid expansion. I mean, and just the reason I was elaborating on that is like, because that's one of those things where it's not going to show up every day because, a big complicated ER procedure, I mean, you're going to have people in the ER every day and it's going to be like an inefficient cost, but it's not necessarily going to be like the 200, 300, 400, however many millions, kind of thing. But when that does hit you as a rural hospital, that's a huge deal,
Yeah.
So it's like, it's one of those things where it's like you probably go and do a lot of simple uncompensated care kind of procedures for relative. I mean, it would still be expensive and like you'd have to deal with those costs, but you might be able to eat that, or you might be able to get some kind of like, some kind of state aid or federal aid to help, some grant money, that kind of thing, to help make up for that loss. But over time, I mean, the more complex, the costlier people, as they start rolling off and they start trying to seek care and they find out that they're, they don't have insurance anymore. I think that's going to be a process specifically that's going to be the thing that becomes more complex and more like complicated and harder over time. Is the uncomplicated care burden.
Yeah. Related to that too, if someone in Arkansas doesn't have health coverage, what do they do if they need care? Do they go to the ER? Are there other places they can turn?
That's a good question, actually. There's community clinics, mm-hmm. so that there's some state aid, and I know a lot of like community mental health clinics as well. Mm-hmm. So there's that kind of thing. But I would say that the ER is a first choice for too many people, and then definitely if you don't have insurance, it's your most reliable source of care for sure, because there's like, walk-in clinics like Harmony Health Clinic here in Little Rock, mm-hmm. but then it's like, just kind of have to show up on a Thursday at 5:00 in the morning and wait in line and hope they can see you kind of thing, and that's the only clinic I've personally seen and experienced, but I would assume that other like, free health clinic kind of things have similar problems.
Yeah. And none of that gets people prescriptions, right? If you need prescriptions.
I don't want to speak. I don't know. I actually
Yeah.
don't know. So with community mental health clinics, actually, I do know a little bit about that. You can get prescriptions through that, but it is a complicated process because of how you need your actual like psychiatrist to see you,
right.
and so the way that they get around that is usually you only have to see your like psychiatrist like once a year or something like that, and then you can see your therapist or your MHPP, at a different location more regularly. So I think, I don't know. At this point, what they do is if you don't have insurance, they get you Medicaid expansion insurance, so I don't know,
Right.
there's like, they can give you, like, they can probably write you a prescription, but it's like, how do you get it? How do you go actually pick it up?
Right.
So yeah, it doesn't really help, if you have like a chronic condition where you need to get medication every month and it's not like, oh, I have something unknown, I need a doctor to check out. It's like, oh, I have diabetes and I need my insulin. No, this doesn't help you at all.
Yeah, exactly. Yeah. And ERs, so I was talking to someone who was like, I went to the ER and they were like, you have this condition. We can't give you the drugs you need. Like, you need to go to a doctor, get a prescription, go to the pharmacy, get your... budget-wise, in terms of like uncompensated care and ER visits and stuff, like, will some of that redound back to the state budget? And do you think there's a way in which this will end up not actually saving the state money, or is it other places that are eating those costs for,
Well, that's a good question, and I'm just not old enough to have been working in this arena before Medicaid expansion, to be honest with you, so I don't know a lot of the answers to that question from like a first-hand perspective, but I do know that we have in the past at least offered funds like disproportionate, whatever those kind of DSH funds that, I don't know, the federal government gives to certain hospitals that have like, particular needs. The state did something like that with state money, and I can actually send you this document, but when we implemented Medicaid expansion, that was one of the cost saving measures, that we got to cut out of our budget. Was we're not going to pay this whatever payments for uncompensated care to hospitals anymore, because now they get Medicaid expansion and won't need it. So there has been in the past. To answer your question though, it's kind of a policy. It depends on what policymakers want to do, because it's like, well, the service providers are just going to eat it. Well, it's actually going to, the consumer's going to get hit first, and then the providers, and then that could matriculate up to the state, but only if they care enough about the people losing health coverage and the providers losing dollars to fix that situation.
Right.
Because I don't think there's like a safety valve there where, oh, this hospital's about to close because of uncompensated care. Now the state's obligated to whatever money to it. There's nothing like that.
Yeah.
So I would say it's like, right now it's just it's a cost shift from the state to service providers, and we'll see how the service providers handle it. That's kind of what I was saying earlier. That's why I was saying earlier before this. To me, that really seems like the central thing. As an advocacy organization, obviously we care a lot about the people losing healthcare coverage, but from my mind, it's like the fiscal side of things, policy side of things. The real problem is that it's not really saving us money, because you're not telling hospitals and service providers, hey, you don't need to see people that are dying, for instance. And if you cut that off, then that's not necessarily a cost shift. It's like morally horrendous, but anyways, like, unless you fix that problem, you're not really saving costs. You're just shifting it from the government to these like nonprofit entities, and then that's the situation we were in before we had Medicaid expansion, and we obviously didn't like that very much. So
right, yeah, definitely. It'll be interesting. I'm curious to see if providers get sort of more vocal about it, if it continues and starts to hurt them.
Candidly, it was very disheartening for me that there wasn't more people speaking up against it. But I think it was a political calculation, because of, like you said, the bargain we were presented was like, if you want the program at all, you have to accept the work requirements. Anyways, I don't want to belabor that point, but yeah.
No, yeah. In terms of that sort of like effort, either before or now that it's here, like, have you guys been were you trying to stop this from happening? Are you working on it now? Are you sort of waiting to see how it all shakes out?
trying to stop. I mean, we did public comments against the waiver request, and we